Discover the stimulus. The elephant in the room this holiday season: access barriers.
Part 4. An evidence-based dialogue. Institutional drivers of hesitancy.
The principal and primary drivers of vaccine hesitancy are not being produced within the community sector, but instead by some actors within the public health, primary care, hospital, education, and government sectors.
This is the core of our argument. The belief that declining immunization rates and hesitancy among Black African Americans are rooted in community deficits is a misconception.
Our summary review of the foundational research confirms the drivers are institutional. We are talking about deep-seated trauma, provider bias, and systemic access failure. This is not community reluctance. It is a rational response to institutional betrayal.
We've compiled the evidence from peer-reviewed journals and state policy reports to illustrate 4 undeniable failure points that demand immediate intervention, not just better messaging, followed by the legislative mandate.
Failure point 1: historical trauma and eroded trust.
The first failure point is the direct consequence of historical and contemporary trauma. The research is unequivocal here.
Multiple studies, including the Integrative Literature Review on COVID-19 vaccination, identify structural racism and trauma as the primary drivers of mistrust. It is the root cause.
The Brookings Report specifies this. Present-day experiences of discrimination directly influence vaccination decisions. This isn't a historical footnote, it's an ongoing active deterrent to public health engagement.
Therefore, any intervention must first and foremost acknowledge past medical harm and emphasize current safeguards. Generic safety information fails because it ignores the context of trauma, as confirmed by the Science Direct study. Failure point 2: provider bias and communication failure.
The second failure point exists in the patient-provider interaction, specifically in provider bias and communication.
The review on racial and ethnic disparities in adult vaccination is striking. A major barrier is simply the lack of physician recommendation. If the doctor doesn't recommend it, the patient won't get it.
Even worse, that same review found Black adults reporting healthcare stereotype threats from a provider were less likely to get a flu shot. The negative impact is immediate and psychological.
The solution is clearly institutional, demanding provider training. The scoping review emphasizes the need for training in culturally appropriate care and the use of frameworks like LEAPS to intentionally build trust during every clinical interaction. Failure point 3: structural access and resource inequities.
The third failure is a matter of structural access and resource inequities. These are the barriers that prevent people from physically complying with public health guidance.
The NC Medicaid fact sheet lays this out clearly for our state. Black children have much lower rates of childhood vaccination. Common causes include a lack of family resources, specifically reliable transportation and time off work, inadequate access to health care, and infrastructure challenges.
This is compounded by the research on county-level barriers, which demonstrate African Americans are more likely to live in counties with higher structural barriers, like technology access and transport issues, that actively impede vaccination. The takeaway is that the system is rigged with hurdles that vulnerable families cannot clear.
Failure point 4: education and institutional narrative failure.
This is where history repeats itself. The problem is not the absence of data, but its deliberate suppression or manipulation.
The 1918 to 1919 influenza pandemic research showed that government downplaying the epidemic and officials instructing the public to remain calm led to widespread desensitization or inuurement to the risk.
We saw this pattern repeat in early COVID-19 response. The 2020 stimulus paper highlighted the tension. Officials worried data transparency might disenfranchise some groups, but advocates warned that the absence of multidimensional data was equally dangerous.
This institutional tendency to control or withhold information, whether through outright censorship, as seen in the Indian Health Service reports, or by simply neglecting to provide transparent, multidimensional data, is itself a powerful driver of the public mistrust that leads to hesitancy. The mandate for institutional intervention.
Our review is conclusive. The determinants of hesitancy, mistrust, fear, and informational gaps are symptoms. The underlying disease is the failure of the public health, primary care, education, and government sectors to create a trusting, accessible, and equitable system.
The solution is not more communication targeted at the community. The solution is evidence-based institutional intervention.
You now have the full 5-point mandate and the unassailable academic foundation to compel immediate action and team formation.
Exactly, and we can accomplish that and so much more if we all open up the lines of communications and genuinely collaborate collectively. So with that, everyone continue to enjoy the holiday season, be safe, and as always, let's remind each other daily to stay alert, be prepared, and survive.